So welcome, everyone. Today, we're going to do a podcast talking about one of the recent articles in the North American Spine Society Journal. The article is The Educational Impact of Early COVID-19 Operating Room Restrictions on Neurosurgery Resident Training in the United States, a multi-center study. And I'm honored today to have two of the authors. If I can ask you both to introduce yourselves.
My name is Tobias Mattei. I'm an assistant professor of neurosurgery at St. Louis University. I'm a fellowship-trained spine surgeon, and I'm the senior author of this study.
Morning, everyone. Dr. Grauer, it's a pleasure to be here. Thank you for having me. My name is Zhang. I'm a fourth-year medical student at St. Louis University School of Medicine. Dr. Mattei is my mentor, and very interested in spine surgery and happy to be here.
Good. Well, thank you both for joining us. It's always great to get insights of people really involved in performing the studies. So maybe just as a kind of to get us kicked off, Justin, maybe you can give us a little bit of an overview of kind of what your thoughts were in doing this study and what you guys found.
Absolutely, sir. It'd be my pleasure. I think it goes without saying that the COVID pandemic has had an unprecedented effect on all aspects of life. Just here in St. Louis, we're starting to return a little bit to a sense of normality. And when it comes to the surgical specialty, these effects materialized in, for example, the transition to telemedicine and cancellation of elective cases, a large percentage of which are spine. With respect to residency training, we saw, for example, transitioning of didactics to a virtual setting. And Dr. Mattei noticed early on that the impact of these changes upon neurosurgery residents have been assessed anecdotally and qualitatively through survey analyses at single center institutions. The existing literature at the time did not really leverage multi-center data or provide any quantitative assessments of the effects of COVID on residency case volumes. So therefore, this study addresses that gap in the literature, and we provide detailed information on neurosurgical case volumes stratified by ACGME case categories. So comparing adult cranial versus adult spine, for example, the urgency of the case. So emergent versus elective, and then stratified by PGY year. So we queried 7 institutions across the country, and we pooled the data and separated by month from March 2019 to April 2020. And in this study, we elected to provide a purely descriptive analysis, given the significant heterogeneity present between multiple institutions and their COVID restrictions. Some cut off earlier, some shut down later, the differences in patient populations, and most importantly, this idea of seasonality. So we didn't feel comfortable comparing March 2019 with March 2020, for example, given the time difference. We couldn't account for this. We couldn't really, undergo any kind of robust model to account for all these effects. And our results were intuitive and expected. We found steady decreases in caseloads in all ACGME case categories in a stepwise fashion from January 2020 to February to March to April, with the sharpest declines being between March and April 2020, which actually made a lot of sense in our analysis, given that out of the 7 institutions, most of them shut down the city's mandated shutdowns in the month of March. So we felt those effects in April. And unsurprisingly, we saw the biggest reduction between April 2019 and April 2020. And that was a 60% reduction in all cases. And unsurprisingly, spine actually had the sharpest decreases, with a 66% decrease in case volumes from March and April 2020. Junior and senior residents both expected similar decreases in caseloads. And actually, juniors experienced a little bit greater magnitude of a decrease at 55% between April 2019 and April 2020, compared to seniors who had a 45% decrease. So no matter what your resident level was, everyone was affected from that perspective. So that's kind of an overarching overview of kind of what we did.
Right. And certainly something we all feel. Dr. Mattei, maybe you can comment just, working with the residents, what did you feel during this time from your perspective? Were you really kind of feeling kind of big changes in terms of kind of experience? And do you feel that that's continuing, or was that a very time limited process?
So I think that the most important point is that when we went through the initial OR restrictions because of the COVID pandemic, We're uncertain. The major factor that was affecting the way we plan the months ahead were the uncertainty. So if we knew that that would last only 6 weeks or 8 weeks, it might have been different in terms of what we planned. But the fact we didn't know if that would take 6 weeks or 3 months or even 6 months or a year. So that was the main problem that I think affected most program directors and faculties in terms of planning. Now looking backwards, we see that, I mean, we had, at least here at St. Louis University, about 4 to 6 weeks of restrictions for elective cases, which significantly impacted my practice in spine surgery, especially with elective cases and the deformity cases. But at the long term, I mean, if you imagine from the resident training standpoint, which is the focus of this study, that affected less than 10% of their annual experience, right? It took about a month out of their year. And I would say most neurosurgery programs, the residents have a caseload, which is at least 10% and higher than the required by the ACGME. So even with that drop, I don't think it affected that much their long-term experience, but that was a concern when we're through the pandemic. We checked with the ACGME, and their guidance was that every program director had the discretion on how to evaluate the proficiency and competence of every resident or fellow, but they wouldn't reduce the case requirements for the residents. So, and to be honest, I mean, now looking backwards, I think that the major impact upon the residents training was not that much related to the volume of cases, but especially regarding it was more a qualitative impact upon their training. And I'll give you some examples. It was not, my restrictions for deformity cases were much longer than just that strict 6-week period because of inpatient bed issues. So even though we had overtime, I could do most of the elective surgeries that were outpatients, but those patients that require a week or more than 3 days as an inpatient, they were significantly affected. The other thing that the other aspect that my practice was deeply affected was in terms of laminectomies for replacement of spinal dorsal column stimulation system. So I do most deformity cases, but I also have at least 1 day a week, which I do the laminectomies. And if you imagine that practice is very dynamic. So I send the patients with chronic pain to pain management, they get the trial with the spinal stimulation and they come back. Everything was shut down. So the patients with chronic pain, they were not getting trials. Of course, there was no emergency on that. Most of them were failed back syndrome. So I would say the impact upon my functional neurosurgery practice in terms of spinal cord stimulation system lasted for at least 6 to 8 months. And only now I'm seeing my practice going back to the volume I had before the pandemic. And of course, the residents lost some of their training during that period, which I'm very confident they will compensate. But I would say the impact was more qualitative and long-lasting than merely the quantitative restrictions that we're able to document in this study.
Yeah. Absolutely. I think many of us certainly felt that very strongly. So there's probably been, I mean, pauses that probably took away some from education, hopefully some lessons learned and maybe even opportunities we took advantage from in hindsight in terms of how things have evolved. I guess to either one of you is a question of just, do we worry that there are things from the pandemic that are going to leave some holes in our education for our residents or other measures we have to take? And I know you hypothesized a little bit of that in your discussion of the paper.
So one of the things we hypothesize is that because most of the observed decrease was in elective spine cases, maybe in the future we'll see an increase in the number of applications for spine fellowships. So all of this makes sense, but at the same time, I can assure that at least from our experience, our residents were still very busy and active. I mean, this very study was a resident of mine in the first week of the pandemic that asked me about any study that they could be engaged. And that was my suggestion. I said, let's study what we're going through. And then instead of just reporting our experience, we reach out to other centers and we're able to pull the data. And one of the things Justin mentioned, and which is true. We were not able to perform any formal statistical comparison because those centers were selected and the homogeneity of the variance was therefore violated, and we're not able to use parametric tests. But that illustrates how, and U.S. editor-in-chief, you probably saw a substantial increase in the number of submissions, at least in the months following the pandemic, because even faculty and residents, they were active catching up with their research and ended up with. So in some sense, we ended up, it definitely affected our practice, but I think as academic spine surgeons, we have been able to compensate in other ways, and hopefully that will have a positive impact upon our careers and the residence training.
Yeah, we absolutely did. Through the, after pauses, we definitely saw increased numbers of submissions, which probably certainly correlates with additional time doing the scholarship aspect of education and practice with that. We've also been a little, at least in my practice, we were a little different than we were. We've continued telehealth and other things. I will say from the outpatient perspective, we have not found efficient ways to integrate our house staff into telehealth. We continue it as part of our practice. I don't know if you guys have seen that as something that's been able to be incorporated into the training process. We've not. And it just, I don't know, maybe there are opportunities there, maybe not. I'm not sure.
Personally, I've been using telehealth since the beginning of the pandemic, especially for the post-operative evaluation. So I would say maybe not the initial post-operative evaluation that requires wound check or removal of the sutures, but for the 6 weeks or 3 months follow-up, getting upright X-rays, or even for those patients with stable fractures treated with collars, we definitely were able to use telehealth. But I've seen some studies in the literature that even in terms of the triage, a lot of surgeons were doing the triage and discussing surgical indications through telehealth. So definitely, I think it depends on the experience of each institution. And despite the limits of telehealth, especially for us that rely a lot on the neurological examination, I definitely think it was a positive impact that will affect our practice.
Great. And, hopefully we're done with these shutdowns related to COVID, but, I think we all are aware that we're not sure of that. Any lessons learned, things that we think will kind of help if it does need to go back to that, or thoughts in terms of how we can kind of best make use of the time, or kind of make sure that the educational priorities are maintained for house staff?
I think one of the main learning points that I had is that even in such a deep crisis as the COVID pandemic, we have to be proactive in terms of developing our strategies, but we have at the same time to be adaptive and not trying to carefully plan 6 months or 12 months down the road because of the underlying uncertainty. And as you mentioned, usually when you're in the middle of the storm, the problems seem much bigger than they ended up being when you look with hindsight. So I believe that this flexibility in terms of developing new strategies, both for residents education, we had a very positive impact in terms of our grant rounds, because we're able to transition to Zoom and have much higher attendance of medical students and even faculties from other institutions. I'd say most of our meetings, faculty meeting, residence meeting, we transitioned to Zoom, and since then we have continued that way, and it has been much easier to gather everyone. But looking forward, I think even for the residents, it's a learning experience on how to manage an acute crisis like that without becoming desperate and thinking that everything we've built so far has fallen apart.
Great.
And Dr. Grauer, I think I can say one thing briefly also from the medical student perspective. I know this study focuses on residents, but as Dr. Mattei alluded to, I think the transitioning of didactic to the virtual setting was enormously beneficial for medical students. Grand rounds, other teaching sessions, faculty coming, so we had Dr. Ali Baj from Banner Health in Phoenix come talk, who otherwise would not have been able to. and medical students are invited to come as well. We're just another little face in the video conference. So from that perspective, enormously beneficial from educational standpoint for medical students, and anecdotally talking to the residents, they kind of felt the same way too.
I do think that there will probably be some benefits that we just didn't even think about, that we all do continue to benefit from. I mean, I'll tell you, at our institution, we continue to do morning sign out with house staff and faculty every morning as a group, still through electronic platforms. And the communication and the kind of input we give to our house staff are much more than they've ever been in that particular setting. And there are other aspects of practice that applies to. So hopefully we can take the positives and keep those things going. Other thoughts that you guys learned from doing this study, or messages you want to share to those who are listening?
One of the points that I like to bring, and that's something that I teach my medical students, especially those I'm mentoring. Sometimes we look to a problem and we say, hey, maybe our study is somewhat limited, or we may not be able to achieve something that will be highly impactful to our scientific community. I mean, this study, when we started analyzing, some people could have said, of course, you're going to observe a massive decrease in those 6 weeks of the pandemic. And so what? I mean, what is it? You're not discovering the wheel with that. And I said, we don't even know, I mean, the impact of the pandemic. We don't know the impact upon each specialty. And we don't even know if that's unique to our institution, how other programs with 2 or 3 residents a year and larger faculty staff were impacted. So even that descriptive analysis provides a background for us to be able to properly analyze the problem and then devise the strategies. So it's just an encouragement to say that whenever you have proper data analysis and careful data collection, even though some of the findings may be expected, I still think there's some important value in pursuing that type of strategy.
I do wonder if we look back even with a further, out lens, with deferred pathology and many people seeing some increased demand after shutdowns, if maybe there'll be some equilibration of the volumes that house staff see that are very hard to see in the short term, but maybe won't be will mute the effect that we see in short-term evaluations. I don't know.
For sure, and that's one of the limitations of our study. We focus exclusively on the initial OR restrictions during the first weeks of the pandemic. But of course, we could have, further studies could evaluate the impact of the second wave of the Delta variant, and especially the bounce back in the number of cases after that, just to see that effect. The fact is that, gathering, especially when you're focusing on multi-institutional data, if you try to analyze 2 or 3 years of data, probably the study will come out 5 years later when the subject is already not that much of such interest. So, but it is definitely one limitation of our study, that we decided to focus exclusively on those initial 4 to 6 weeks restrictions during the acute first wave of the COVID pandemic.
Right. Any other thoughts from either of you? If not, we'll probably wrap it up. It's really helpful to get the insights from the paper. It's great to hear kind of thoughts in discussing this with you, and really appreciate you publishing with the North American Spine Society Journal. Thank you.